it's the prerogative, of course, of the chair to lead off with the questions, and it's a good place to be in many ways. But I guess preliminary questions, Mr. Hill, and I understand that we had what would be a demonstration or the project in different states, and now it's going to be permanent, and there are going to be some structural changes which may address some of the concerns that some of the physicians and healthcare providers have regarding professional staff that will be with the permanent RAC, and I know that's the term that we use now. But I do have a question, that is, how many physicians will each RAC be required to have on staff? I think you pointed out that there's going to be a medical director, and I understand that, and as well as a coding expert. But we're talking about physicians because I've been told that we have non-physicians in essence passing on a physician's judgment on what was medical necessity. So how many doctors, how many MDs are we going to have required or mandated?
Right. The requirement for the permanent RAC program is that each recovery audit contractor have a medical director who is a physician. And the concept here isn't to enumerate the absolute number that has to be there. Do they have to have one or do they have to have five? But the concept here is there's one medical director who's overseeing the judgment of the other clinicians, whether they're nurses or therapists or coding professionals who are sort of making the judgments on claims, whether or not they're going to get paid on review or not. And it's that physician who is making the ultimate determination. If, for in the example you've used, the RAC is going to make a judgment to overturn a claim, the physician would be the one overseeing that process and making that judgment.
All right. What do you think that would be, and I guess it's a claim or a caseload of a medical director? When we say the permanent RAC will have a medical director who's a physician who's going to be overseeing the non-physicians and such, but realistically, the demands on someone's time, I mean, how many claims are we talking about? How many, is there a process that will require the review by the medical director, or is that going to be something that will be established within each independent and permanent RAC?
Right. I think it would be established within each independent and permanent RAC, but again, I think that what we're talking about here are processes as much as workload, so which is to say that it's not the notion here that the physician would look at each and every claim. So, for example, you may have a series of claims dealing with one set of one benefit category, one particular issue. And I think that the job of the medical director would be to ensure that there are processes in place as the nurse reviewers or the therapists or whoever making judgments on the claim are making those judgments. They're making them consistently and in a way that the physician could sign off on that ultimate disposition, not that they would look at each and every claim.
What evaluation did you have is before we went into the permanent phase of how it operated, how the RAC system operated in those other states? I have some information that obviously been provided to me, and it said that an independent contractor reviewed a sample of medical necessity decisions made by the California RAC and found it is an error rate of at least 40% or up to 40%. And I'm just wondering, did you ever have any kind of independent analysis of the work that was actually being done by these RACs in these selected states?
Absolutely, and that independent evaluation that you discussed there was something that I directed in California in particular, which was our sort of poster child for bad decision-making on the part of the RACs. A lot of that, I would say most of that, had to do with a particular benefit area, inpatient rehab services in hospitals in California, where the RAC's judgment on medical necessity ultimately didn't end up conforming with what CMS thought the right judgment would be. And after we had heard from a series of folks, hospitals in California, some members of the California delegation about what was going on there, we sort of suspended that review, sent in an independent evaluation to make sure that the RACs were making, that particular RAC was making correct decisions on those particular claims in California. Now, that was specific to those sets of issues. It's also the case that because of that, we have built into the process an independent evaluation of every RAC's reviews. And so, say the RAC does 100 claims. We're going to take a sample of those claims and independently going to review those and say, did they make the right decisions on that review that they did on a sample, and that will help us direct whether or not we need to do corrective action with the RAC or whether they're going in the right direction. But it gives us a little more comfort that they're making the right decisions on an ongoing basis.
So that is going to be built in the permanent RAC arrangement where you actually will have some oversight, again, taking a sample of those, let's say, medical necessity challenges and claims and such.
Correct. And actually, on the medical necessity issue, even more important, because what I've just described is what happens after the RAC has made a decision, sort of like, so it's already had the impact on a physician or a hospital. More important than that, I think, is we've put in place a process, what we sort of euphemistically call in CMS a new issue review process. And so you think about it this way, if a RAC wants to open up a new set of reviews on a particular issue having to do with medical necessity in a particular state, before they can begin that review in earnest, in other words, before they can start asking for a lot of medical records from a lot of different providers, they need to come into CMS and they need to talk to me as the CFO, and they need to talk to the people, the physicians who do our coverage policy and the people who do our payment policies, who really write all the policies and explain how they're going to do that review, the rules that they're using to do that review, and we need to sign off and agree that what they're doing comports with the policies that we've got in place. Precisely so we don't get in the situation like we did in California, where the RAC was reviewing rehab claims in a way that ultimately we didn't agree with. And I think that on the front end puts a level of oversight and discipline in the process that we don't have now, and quite frankly we don't have for any of the other sorts of review activities we have in Medicare. That would be unique to the RACs, and I think will provide for me anyway, a much greater level of comfort and oversight for the RAC processes.
And I don't mean to misinterpret what you're doing, and I think it's done in good faith, but I also believe that you see some real potential for things going haywire or not as we would prefer that it perform. One thing that concerns me is this contingency fee arrangement, which I understand that concept, but I've never seen something like this, to be honest with you. Let me get this straight. If the RAC finds that a claim should be denied, or a medical necessity claim, a denial, it's that first step, are they reimbursed at that point? In other words, are they entitled to the contingency fee at what stage? At the initial finding?
They are only entitled to the fee when the overpayment amount has been recouped by Medicare. So to the extent they've identified a claim, a medical necessity claim that should be overturned and recouped by Medicare, to the extent that Medicare recoups that amount, the RAC is repaid. If, for example, a provider, say it's a significant amount, and a hospital, this is typically the case in hospitals or home health agency, has said they'd like to pay that amount over time, they'd like to have an extended repayment plan, the RAC only gets a portion of each payment. They don't get the full amount right away. They get it as they get the percentage as Medicare gets its amount. On the back end, to the extent a provider appeals that determination, so the way the Medicare process works now is typically the amount is collected and the appeal happens. To the extent a provider appeals and wins, in other words, that appeal is overturned, the RAC has to pay that money back. They don't get to keep that money. And so, well, that's how it works.